Hello, this is Kathy Bush, and welcome to the DandleLION Medical webinar titled Complementary Therapies in the Neonatal Intensive Care Unit. Our faculty presenter this morning is Sarah Bakke. Sarah started her career in a Level 3 NICU in Indiana and has worked both in Level 3 and 4 NICUs over the course of her career. She is currently a staff nurse in the NICU at the Nemours Alfred I. DuPont Hospital for Children in Wilmington, Delaware, and is working towards her MSN as a pediatric nurse practitioner at Drexel University. Sarah has led a number of neuroprotective initiatives during her time at Nemours, including launching a language nutrition program, founding a multidisciplinary neuro-NICU committee, and organizing quality improvement projects. She has developed the NEO-CT survey to assess the attitudes, knowledge, perspectives, and use of complementary and alternative therapies of staff in the NICU on a local and a national level. And we did publish a survey, Sarah's survey, and we hope that you had a chance to take that survey and be part of Sarah's research. So welcome, Sarah.
Thank you, Kathy. I'm so excited to be with you all today to talk about my work in complementary therapies. So here are our objectives for today. So I want to start by looking at some broad definitions and concepts in complementary therapies to get started, just so that we all have the same language. And then I'll be discussing complementary therapies in the NICU and going into some detail on safety and efficacy, what sort of benefits we might see from using these therapies in the NICU, and the barriers that exist in implementing them, not just in the NICU, but in the broader hospital sense. And then I'll present the NEO-CT survey and discuss how and why I developed the survey. So I want to start by briefly defining some terms and discussing the role of the National Center for Complementary and Integrative Health, the NCCIH, in the United States. So generally, people use the terms alternative and complementary interchangeably, but they're really referring to two distinct concepts. So complementary health approaches include non-mainstream practices and products together with conventional medicine. So for example, incorporating massage with an NSAID regimen for muscle soreness. So in that approach, the non-mainstream and conventional practices are complementary to one another. Now, true alternative medicine is using non-mainstream health approaches in lieu of conventional medicine. And that's not really a common practice in our country. And so I'm more talking here about the complementary health approaches that would be used in conjunction with conventional medicine. Now, another frequently used term is integrative medicine. And this is a coordinated approach to combining those conventional and traditional medicine practices with complementary health approaches. I mentioned on the previous slide the National Center for Complementary and Integrative Health, or the NCCIH. So in the United States, the NCCIH is a federal government agency, and they're a subset of the National Institute of Health. And their mission is to fund and conduct research on complementary health approaches. So the NCCIH research model is pictured on this slide, that circular image in the background there. So let's dig into what this graphic is showing us to understand the scope of what is meant by complementary health approaches. And it's really like an umbrella term. So according to the NCCIH model, complementary health approaches are organized into two subgroups, which are pictured there at the center of the model. So on the left, that orange half of the circle is mind and body practices. So that's a broad set of complementary therapies that includes things like acupuncture, acupressure, massage, healing touch, therapeutic touch, Reiki, other forms of energy medicine, spinal manipulation, and our traditional Chinese medicine practices. In the green on the right, the other half of that circle are natural products. So natural products include herbs, botanicals, vitamins and minerals, and there I mean things that aren't standard dose vitamins and minerals, and probiotics. So natural products are frequently referred to as dietary supplements and are widely available over the counter without a prescription. So the NCCIH studies the effects of these mind and body practices as well as the natural products within 6 dimensions. So that blue ring sort of around the circle are these 6 dimensions that they're looking at. So pain, interactions and safety, biological effects, mechanisms, meaning, what is the mechanism of action, healthy behaviors, stress, anxiety, and other symptoms. So what symptoms are these products or practices working to help? I found it interesting, so I decided to include it here, that given the large scope of their mission, I mean, that's a huge undertaking what this model is showing us, and given that large scope, the mission and the staffing and funding of the NCCIH seems to pale in comparison. So for the fiscal year of 2019, the agency had a little under $150 million in funding and 68 full-time staff members to accomplish all of that mission that we talked about. So it's interesting when you think about, what the consumer demands. So what are our patients and their families, what's their demand for these types of practices? And for example, the essential oil market alone, the global 2022 market size is estimated to be over $11 billion that they're projecting. So in the US, there seems to be this mismatch of research funding versus consumer demand. So what is the demand? So complementary health approaches in the United States, we actually really have a good source of data for knowing how large the demand is. And the National Health Interview Survey, or NHIS for short, it's an annual study that is conducted by the National Center for Health Statistics, which is part of the CDC. And they're looking at broad use categories in pediatrics and adults for these complementary health approaches. So every 5 years, the survey includes a supplement looking at the use of these complementary health approaches. And most recently, that insert was included in 2012 and 2017. So looking at some data from this survey, we see that over 30%, so 33% of US adults and over 11%, specifically 11.6% of children ages 4 to 17 that were surveyed used at least one complementary health approach. And the most commonly used approach were natural products, so looking at those dietary supplements other than standard dose vitamins and minerals. What's also interesting in the context of our patient population in the NICU and when those babies go on to graduate from the NICU is that the usage of complementary and alternative therapies increases dramatically for children who have chronic medical conditions that affect their activities of daily living. So kids with cerebral palsy, conditions affecting their emotions, attention and behavior. So this is our like ADHD autism population, which is very high in graduates from the NICU. And over 50% of children with a chronic medical condition reported using at least one complementary health approach over the past year. Now, in terms of spending, because a lot of these things are not covered by insurance, about 59 million Americans spend money out of pocket on complementary health approaches, and their total spend, and that's annually, their total spending adds up to over $30 billion a year. And according to a 2018 Consumer Reports survey, 1 in 5 consumers report that they prefer complementary medicine, and 12% would prefer natural remedies over prescriptions or traditional medicines. So I think a key takeaway for us as healthcare professionals from the NHIS study is that as consumers' use of these complementary health approaches grows, there too grows this stigma around their use. And I'll explain what I mean by this. So the majority of adults reporting the use of at least one complementary health approach, and particularly older adults, said that they did not discuss their choice with their medical provider. So several reasons were reported for this, including that simply they were not asked by their provider, or they didn't feel like there was enough time in their appointment to talk about it, or they perceived that their provider would react negatively. So I'll come back to this because, interestingly, when we survey providers, their perception differs. So healthcare institutions certainly have taken notice of the consumer demand for complementary health approaches. And in 2010, there was a large survey done of complementary and alternative medicine survey of hospitals. So from that survey, over 40% of institutions were reporting that they offered one or more complementary healthcare approach. And there's a more recent survey in 2017 that tells us that that number has increased to over 60%, reporting at least one complementary health modality offered to their patients. And while use of complementary health approaches is becoming more prevalent within the U.S. healthcare system as a whole, we're not seeing that use is standardized, and there's a limited amount of U.S.-based research. So in 2017, there was a survey of pediatric inpatient facilities, and at that time, only one hospital reported having a written policy directing the use of complementary health approaches. And the most commonly used therapies that they were reporting were massage and healing or therapeutic touch, with over 30% of sites reporting use of those. Now, approximately 50% of sites reported that they allow families to administer some herbal preparations and supplements, but only 1/3 of those sites reported that pharmacy was involved in screening those preparations. So why do we see that there's sort of this mismatch? And the answer is complicated, but I think that there are certainly tremendous barriers to implementing these complementary health approaches in the U.S. healthcare system. So there are some identified barriers for health professionals in the literature. And in 2007, there was a survey conducted of nurses, physicians, and allied health professionals at pediatric and women's care centers. And earlier, we were talking about the results of that NHIS study, where the patients said that they perceived that providers were not supportive of their use of complementary health therapies. However, what the caregivers were reporting in this survey was that they did support their patients. They felt like they supported their decision to use complementary health approaches, but they felt that they had a limited scientific knowledge regarding these complementary health approaches, because it's not part of many standard curriculums, certainly not in 2007 for physicians, nurses, et cetera. And also that they struggled discussing the therapies with their patients. So, how do you have a discussion, a supportive discussion with a patient when you don't really understand the therapy or the product that they're asking you about from a scientific standpoint? So aside from the challenges of limited research or limited caregiver knowledge of existing research, there are the same barriers to implementing any practice change. So there are staffing challenges, limited resources. We're all expected, now to do more with less. We're all understaffed. We all have trouble with supporting initiatives in the hospitals. And the vast majority of complementary therapies are not covered by insurance. So hospitals struggle to staff providers for these positions when the services they provide are not billable. And that's just a reality of, the business of healthcare as it is today. fatigue and burnout. So burnout is a pervasive issue throughout the healthcare system. And, you know, when we're feeling burnout, it's difficult to find that energy to put into programs that are considered sort of like the icing on the cake, you know, not part of our standard core care. So now that we've laid some groundwork, and I hope you all have a better understanding of what I'm talking about when I'm referring to complementary health approaches, I want to talk about some potential applications for complementary health approaches in the NICU. So a lot of what I'm going to present comes from two primary sources. So I just want to take a moment to introduce them. So one is a wonderful summary of the literature that was actually done way back in 2001, but it really provides a great overview of all the different types of complementary health modalities. And this was done by a Dr. Jameson Jones and a nurse, Nadine Cassidy, from San Diego Children's Hospital and the Center for Collaborative Healing in San Diego. And they gave this very robust overview, like I said, of various complementary health modalities with theoretical NICU applications. And at the time, they were organized according to the framework that the NIH used. So it wasn't that circle that we were looking at before. They used to have a different model. So if you do go back and look at the article, it's in my reference list. But I've reorganized the information according to the new model. So it might be a little confusing if you go back and look at the article. But I also pulled information from the SENSE trial, and this was out of the University of Washington at St. Louis. And SENSE stands for Supporting and Enhancing Sensory Experiences. And in the article I've listed on the reference slide, you'll find their integrated review of the literature and a nice summary chart of their findings on what sensory support therapies had substantial evidence according to a gestational age. And that chart is listed here on the right there, that picture. And I also have on the left a picture of the landing page for information about the program, which is what you'll see if you click on the link or if you navigate to the link there at the bottom of the slide. Okay, so I'm going to go through these as they're organized by the NCCIH framework. And some of the applications will be theoretical, meaning there's a mechanism of action that has been identified in either animal studies or adult pediatric human subjects for a given therapy, but no neonatal research yet. Other applications do have some pilot study or clinical trial data in neonates that I'll discuss. And so first I'm going to look at these mind and body practices, so that orange side of the circle. So light therapy. So one form of light therapy we use in every NICU around the world, right? We use phototherapy, which is useful, as we all know, in lowering bilirubin. But we also have studies showing that the phototherapy lights, aside from lowering the bilirubin levels, also have other cause other metabolic alterations, such as increased gut transit time. So could there potentially be desired physiologic effects from other wavelengths of light? For example, some studies show that low-level laser therapy, so that's that LLLT, the second one listed, or photobiomodulation applied to the forehead, and this is in adults, applied to the forehead increases frontal cortical blood flow and metabolism, decreases inflammation, stimulates neurogenesis, and reduces depression scores in patients with major depressive disorder. And there's also some studies looking at its use in wound healing or sports rehab medicine. So you might see this type of therapy if you are at a physical therapy office or in some of the wound care programs in your hospitals, that they use this laser therapy to stimulate new tissue growth. And then the graphic on the right here is another type of light therapy, a near-infrared light therapy. And you can see that it causes a number of other desired effects in human subjects. So while there are no NICU studies, you can see where there could be potential applications in the neonatal population. Cycled lighting. is another type of light therapy. So cycle lighting was recommended from the SENSE program findings for ages 23 to 36 weeks post-menstrual age, and I'll refer you to their study. So as we're going through all these, I have references that correspond to my reference list, so you can go and look at the source article for each of these, because I'm really just, highlighting some things. But the SENSE program findings were that this was beneficial, forms of cycled lighting in terms of helping to support healthy sleep-wake cycles in neonates from 23 to 36 weeks post-menstrual age. Now, a 2016 Cochrane review also found that maybe cycled lighting versus continuous bright light or near darkness had some benefit, but recommended more studies. Sound therapies. So auditory exposure is something that's tremendously important in supporting healthy development in the NICU. And it's been well studied in the literature. Music therapy, in particular, has really gained in popularity in NICUs with therapies such as simulated heartbeats to more traditional live singing and instrument play. And studies have documented benefits such as improved organization, decreased agitation, and improved oxygen saturation levels, to name a few. And in a 2014 study out of Turkey, they looked at the effects of pairing this, the music therapy with a multimodal approach, meaning that they coupled it with lavender aromatherapy, music therapy, and then a vibration, and found that it decreased stress in newborns and favorably affected their behavior. So they concluded from that study that, these complementary care applications, especially aromatherapy and music therapy, could be something that nurses could utilize in the NICU. We do have a lovely photo here of a music therapist singing to that cute little baby from the Children's Hospital of Orange County blog. Language nutrition, which is a particular area of passion for me. So this is the idea that just as food nourishes the body, words nourish the brain. So meaningful auditory exposure has been shown to have a profound impact on outcomes for hospitalized neonates, as well as the term well baby. So the SENSE program discusses benefits of maternal voice specifically, and also talks about the live or recorded music benefits as well. This is probably one of the more exciting areas, I think, in terms of potential, and certainly what's out there in the literature on emerging neonatal applications. And we can think of aromatherapy in the NICU in a few different ways. So probably when you say aromatherapy, most people think like your standard essential oil type aromatherapy, but really when you think about it, mom scent and mom's breath smoke, that's a form of aromatherapy. So scent cloths, which were part of Dr. Welch's family nurture intervention, is a form of aromatherapy. And then of course your kangaroo care, skin to skin, that's a form of aromatherapy. An emerging use of aromatherapy is in pain and stress management using essential oils, which are derived from herbs and flowers. And I'll go more into what an essential oil is in a little bit. But here I'm talking about inhaled aromatherapy, so via an aromatherapy patch. So in the picture, there's like a little white patch that is next to that baby on the green Bakke hand. And that patch is called a BioS patch. And it was part of a clinical trial that completed last year in Kentucky that showed that the use of aromatherapy in neonates with NAS, so specifically lavender and chamomile, showed a significant reduction in not only the length of stay, but also a 40% reduction in the morphine use, which is just incredible. And they actually did have investigational drug approval from the FDA for that study. Another aromatherapy study looking at lavender oil on infant vaccination pain. That was a study looking at giving babies aromatherapy prior to an injection. So these were like term 2-month-old babies, giving them that lavender aromatherapy before their vaccination injection had a significant impact on their pain. And I'm going to go into more detail about that study specifically a little later. But could there potentially be other applications for pain and stress management in the future in aromatherapy? So, touch therapies. Our tactile sense is actually the first to emerge in utero, so tactile reactivity happens very early in gestation. So certainly there's a lot of potential here for touch therapies in the NICU. Massage is probably the most highly studied, certainly with the Neonatal Touch and Massage certification and the work of Kara Ann Weissman. And it's been shown to improve neurodevelopmental outcomes, decrease pain and stress, and improve bonding. So the link to that is at the bottom of the page here if you want to read more about that. And massage is also discussed in the Sense Integrative Review that I've been referring back to. Reflexology is another application which has some emerging literature specifically in neonates. So certainly a lot out there in terms of adult research, but neonatal research is also coming out about reflexology. So this is an ancient healing method, and it's based on the principle that reflexes in the hands and feet are linked to specific organs and glands throughout the body. So the theory here is that applying pressure to a reflex zone will stimulate blood flow to a specific area or organ, which increases the production of endorphins and may help eliminate waste. So reflexology is based on the concept of chi, or the flow of life energy, and that our chi can be blocked or disturbed, and that with reflexology interventions, that balance can be restored. So theoretical applications were proposed by the San Diego group that wrote that 2001 article, that they thought that reflexology therapy could be used to help babies in the NICU, and they thought maybe in times of fussiness or disorganization that it might help to energetically help the baby regroup and become more organized, perhaps increase blood flow to the gut to aid gastric motility. And although they were talking about these things theoretically, now that we do have some emerging studies that have come out. So these are two studies that I listed that I thought were interesting. There's a 2019 study from Iran, and this is a small study on 31 infants with NAS, and they were randomized to either receive foot reflexology, then auricular acupressure, and I'll talk about acupressure in a moment, or vice versa. They found that the reflexology was effective in decreasing the NAS scores, and that the acupressure was as well. However, it was dose dependent, so a 15-minute session was not as effective as 24 hours continuous acupressure. And you can find that full citation in the references at the end of the presentation. A 2015 reflexology study was done in Turkey with 60 term infants and looked at the effect of foot reflexology prior to vaccine injection, and found that the infants in the reflexology group also had decreased pain on the FLAC pain scale, lower heart rates, higher oxygen saturation, and shorter crying periods than the infants in the control group. And there are more reflexology studies. I listed a few additional that I'm not going to go into in the, on the references list. Craniosacral, and that picture on the right, I should say, is an example. You can see how the different zones on the baby's foot are linked to different areas of the body. Craniosacral therapy, so doctors of osteopathic medicine, you'll see like DO next to their name, Those in pediatrics who practice biomechanical manipulation, this would be in the category of craniosacral therapy. So basically, the thought is that labor and birth can produce a malalignment of our craniosacral structures that can lead to altered function. So, for example, strain in the occipital bones can induce nervous system dysfunction, such as hyperactive peristalsis, hypertonicity, and irritability. And the thought is that of craniosacral therapy, or the theory is that through manual manipulation and myofascial release, these dysfunctions can be avoided or reversed. So in 2016, there was a feasibility study done in Austria on a very small number of infants, so this was less than 20. And they showed that there were no adverse outcomes from using this therapy, but saw that they didn't show a statistically significant benefit. So they sort of concluded that, maybe that they could do a larger pilot just based on the fact that it didn't do any harm and showed equivalent outcomes, that they wanted to do a study with more infants to test it further. So I mentioned acupressure on the previous slide. So we're going to talk now about types of energy healing. So acupuncture is part of traditional Chinese medicine. And I should also say that I am not a licensed Reiki therapist or a healing touch therapist or an acupuncturist or any of that. So hopefully I am not, hopefully I'm doing a good job of explaining these things in simple terms, but certainly at the end we'll be able to take some questions. So acupuncture is part of traditional Chinese medicine, and it's an energy-based treatment centered on the concept of qi, so our body's healing energy. I mentioned talking about the reflexology, so this is the same qi. So our qi circulates throughout the body on specific pathways referred to as meridians, and when obstructions occur, then disease results. So we have the classic version that we all think about with the needles. So very thin needles are inserted along these meridians by a licensed acupuncturist. But there are also methods that use electrical stimulation, heat or laser. So I don't have a picture of it, but it's sort of like a little device with a laser at the end of it, and that can be used in lieu of the needles. Now, acupressure is a more popular form in pediatrics because it's less invasive, and here pressure is applied rather than physically inserting a needle to the acupuncture points. And the San Diego group discussed several neonatal applications, including auricular acupressure for drug withdrawal, just like that study that I talked about on the previous slide with the reflexology. They've also done studies with acupuncture or acupressure that have shown benefits for colic, constipation, post-operative oliguria, and pain control. And acupuncture is currently used in China pretty extensively in neonates and those in the Nicu, and they treat jaundice, skin issues, teething, pain, ear infections, constipation, and peripheral nerve injuries. And this photo is of a acupuncturist using the needle acupuncture for an infant with colic. And the acupressure, they, like the group that did the 24-hour, they used these like magnet things to create the acupressure points. So when you're thinking like how did they do 24-hour acupressure, that was how they did it. Reiki is a non-invasive energy healing practice involving the body's chakras. So the Reiki therapist will transfer energy through the hands to a patient with their hands over but not touching the body of the patient. So the purpose is to restore the body's energy to balance, relieve pain, and accelerate healing. So in adult studies, it's been shown to calm respirations, lower blood pressure, and decrease stress. And the San Diego group discusses potential neonatal applications for Reiki including enhanced recovery from infections, stabilization of respirations, decreased bronchospasm. And in a 2018 pilot study that was done in Ohio, so that's that safety of Reiki therapy for NAS, they looked at the use of Reiki in this NAS population and found that it was a safe intervention for NAS, and they did show a small but not statistically significant decrease in NAS scores for the Reiki intervention group. And healing touch is another energy-based therapy. So this was actually developed by nurses, and it focuses on clearing and balancing the human energy system through touch. So healing touch is one of the more well-studied interventions in the United States, and completed studies have shown benefits in depression, diabetes, cancer, back injuries, pain, anxiety, wound healing, immune system enhancement. And in the NICU, this therapy can benefit patients, families, as well as staff. So in my hospital, we do have a healing touch department, and they offer sessions on a weekly basis for staff, but we're also able to place referrals for our patients, and families can also schedule sessions for themselves or at the bedside, sort of like a family therapy. A nice integrative review of healing touch was published in 2011, sort of looking through all the different research and applications for healing touch. And that was in the Journal of Holistic Nursing that I have listed there. So moving to the other side of the NCCIH research priority circle and looking at natural products now. So homeopathic medicine, or homeopathy, is a medical system that was developed in Germany over 200 years ago, and it uses diluted plants, minerals, and even animals. Like there's some use of like whole crushed bees. Homeopathic medicine typically contains very small, dilute, like I said, amount of substances that would in large quantities cause symptoms of illness in healthy individuals. So practitioners use this, so homeopathic practitioners use this in tiny doses to provide a positive benefit. And most people using homeopathic products don't necessarily go to a doctor of homeopathy, but they self-prescribe these things for colds and musculoskeletal pain. And that NHIS study that I talked about at the beginning found that about 5 million adults and about 1 million children used homeopathy annually. And of the 1.8% of kids that reported using it, only about 0.2% actually went to a homeopathic practitioner. And there are some fairly controversial things about homeopathy in the United States. The use of like homeopathic vaccines in particular is a pretty hot button topic. But the NCCIH website, I have linked there, has information, and you can read more, because I certainly can't go into all of that right now, but you can read more about homeopathy and what they have to say about the risks and benefits, and particularly the vaccine topic, because I know that is just in general a hot button issue, and parents do sometimes ask about the homeopathic vaccines, or I've had them ask me about them. So most people use, botanical or herbal medicine is different from homeopathy. So homeopathic medicine is the type of medicine that was created that 200 years ago in Germany. Now, botanicals date back to ancient times. So we're talking like 400 BC. These substances were used in a variety of medical applications by ancient civilizations. Now, when we're looking at our current pharmaceutical applications, there are 25% of substances first isolated from plants, or I should say the other way around. Substances first isolated from plants account for 25% of our modern pharmaceutical agents, and another 25% come from chemicals that were first found in natural products. So, for example, digitalis and caffeine are herbal. Caffeine is actually the #1 selling herb therapy in the United States, and as we know, we use it for apnea and bradycardia in infants. Herbals and botanicals are highly utilized, and as I said in the beginning of the presentation, they're the most used complementary health approach in the U.S. And in Europe, Germany in particular, medical providers will actually write prescriptions for botanicals. So they write over 10 million prescriptions annually for herbal medications. In the U.S., depending on the formulation and route of administration, botanicals can be considered food supplements, drugs, or cosmetics, and they're regulated under the Federal Food, Drug, Cosmetic Act or the Dietary Supplement Health and Education Act. And you can access a wealth of information about what regulations there are and also research studies and clinical trials through the American Botanical Society website that I have linked there. So some infant examples of the use of botanicals would be like chamomile and calendula cream for diaper rash. They're over the counter. You can find, it's called ripe water for colic. So this is a combination of lemon balm, fennel, and chamomile for colicky infants. Calendula is used in Russia to treat conjunctivitis. So there's a picture here from a website, Dr. Wheel's website, and he's a prominent integrative medicine practitioner, and that's a picture of the calendula flowers and a salve that is made from that calendula flower. So I have here listed an example of a study that was conducted in 2017, and this was an open randomized control trial that was done in Italy that compared the use of chamomile, melissa, and a probiotic alone, and simethicone in the treatment of colic. And there were 176 infants included in the study, and so they gave some babies that mixture, some babies the probiotic alone, and then some babies the simethicone. And what they found was that it was the herbal and probiotic combinations that were significantly more effective than the simethicone or the probiotic alone. Essential oils are another topic. So I briefly mentioned the aromatherapy with essential oils. Essential oils can also be used in topical and ingestible forms as well. So essential oils are natural, volatile, meaning that they are easily vaporized, aromatic compounds extracted from botanicals. So there are some topical and oral routes of administration that might have potential benefits in the NICU. However, essential oils are very highly concentrated. So while we're talking about homeopathy, this like very diluted formulation of a given botanical, when we're talking about essential oils, we're talking about very highly concentrated, potent botanicals. So there's a lot of potential risk involved in using these for sure in the neonatal population, but also great potential as well in the topical route. Particularly, there are some studies out there. So looking at safety and efficacy for topical applications, colic is a common issue for babies, and parents are always struggling with what they can do to help soothe their colicky baby and decrease their crying time and preserve sanity for everybody. And a 2012 study in Turkey looked at 40 infants between the week 2 and 6 weeks of age, and they were gestational ages 38 to 42 weeks. And they showed that a simple abdominal massage, so these were mothers that had these colicky babies at home, and they were taught how to do this simple abdominal massage with a dilution of lavender essential oil with a carrier oil like olive oil. And they massaged their colicky infant's abdomen once a day and decreased the length of crying time of their colicky baby by several hours per day. So that is certainly something that could be an application that could be looked at. So I want to take some time now to really dig into one specific article. And some of the default responses I think that come from most discussions about complementary therapies in the NICU is, show me the evidence. And there's this wide perception that there's just not evidence out there. So I wanted to do a bit more of a thorough look at one of the studies that I mentioned earlier. So this was that lavender oil for vaccination pain study. So this was a double-blind randomized controlled trial of 97 infants that was conducted in Iran. And the infants started the lavender oil or placebo aromatherapy 1 minute before injection. Then the pain was assessed 3 times. So they used the neonatal infant pain scale for this. And they gave the babies a pain score before vaccination, at 15 seconds, and at 5 minutes after vaccination. And the duration of crying was also measured in both groups. So from the time of the injection to when they stopped crying, how long did that take? 43 infants were given the lavender, and significant findings from this were that the 5-minute nips for the infants that received the lavender, as well as the crying time, was significantly lower compared to the babies that received the placebo aromatherapy. And the researchers felt that that potential aromatherapy interventions like this could be applied routinely for pain control and vaccination and other invasive procedures. So what's the mechanism of action? So why would the lavender reduce the pain in these babies? So let's talk a little bit about lavender. So lavender oil is obtained from the flowers of lavandula, and I'm going to not pronounce this right, but I'll try, angustifolia by steam distillation. So whole lavender oil and its major components, linalool and linalool acetate, are used in aromatherapy. So this is a photo that looks at lavender and repelling moths, which I'm not going to talk about, but I thought that it did a really good job of looking at the different chemical compounds that are in lavender oil. So what I want to focus on is the top left there, so the linalool. And that is a terpene, which is a type of hydrocarbon. So the linalool is a type of compound that is produced naturally by the lavender, and these types of chemicals, the monoterpenes in particular, which is what linalool is, it's a type of terpene and specifically a monoterpene. They are chemical compounds that are produced by plants, and they're what give plants their smell and taste. So common physical characteristics of monoterpenes in particular is that they have a low molecular weight, meaning that they're small and light compared to other types of compounds. They're clear in color, they're free-flowing, so not viscous. They have a high volatility, which I mentioned earlier, and that just means that they vaporize readily, and they have a strong aroma. So linalool, being a highly volatile compound with a low molecular weight, is readily inhaled and absorbed. And when it does, so here we're looking at what the analgesic effect of the inhaled lavender is, and specifically the linalool. So that linalool component of the lavender does have a mechanism of action that has been shown in animal studies. So when that linalool is inhaled and absorbed, it activates hypothalamic orexin neurons. And they have been shown to be one of the key mediators for pain processing. So pain processing is an incredibly complex process. So how humans and how babies perceive and respond to pain is a topic that would need its own hour plus probably days to fully explain. So I'm just going to look at this one specific component, and it is unfortunately an animal study, which, you know, is upsetting, but it does help us to understand how this linalool works in the treatment of pain. So in this study, mice who experienced a painful intervention first received linalool aromatherapy, and they were able to show that the linalool worked by activating hypothalamic orexin neurons. So you can see the picture there of a noxious stimuli activating their orexin neuron, and then there's that arrow going down to a slice of the spinal column. And so it works by sort of down-regulating the pain. So they concluded that analgesic circuits triggered by olfactory input, meaning aromatherapy with the lavender and specifically the linalool, might be inherent in the mammalian brain. So again, in animal studies, so I know everyone's thinking, well, like, does this exist in babies? And what they found was that orexin neurons do reach adult levels by postnatal day 7, and they're fully functional by 21 days. So the infants in the vaccination pain study were term infants at 2 months old. So it's reasonable that the analgesic effect seen from the lavender aromatherapy could be from the linalool activation of the orexin neurons. So this brings me to my survey. So how did I develop the survey and why did I develop it? So I'm going to tell a story from my unit, and this was several years ago that I first started this work, and I am a staff nurse, was a staff nurse then as well at Nemours, and we had this baby that had these parents from the Amish population. So we take care of a lot of Amish population in our area. And in their culture, they have these aromatherapy, and I guess they too do like topical as well, who prescribe regimens based on what's going on with a person in their community. So they would go to this person just like they would a doctor in their community, and this person, this aromatherapy or this natural healer, I guess, would say, here are the things that I think would help your baby or your child get better. And so we had this family who asked if they could bring that person from their community to the unit to visit, and they brought this person in, and then one of the things she wanted to do was this abdominal massage, this belly massage with the lavender. And I don't remember, there were some other things too, but it was specifically the lavender. People lost their minds. Like the nurses had such a strong opinion about it one way or the other. And at the time, I did not use essential oils, so I was completely unfamiliar, but it was so striking to me, the strong reaction that this caused on the unit, that I thought, man, why is that? Like, why do they have such this strong opposition? And there was this great sense of fear too, like just fear of the unknown, not understanding how would we even know if this was really lavender, like, what harm could this cause the baby? There were just a lot of different things, where on the other side, there were people who said, like, how dare we question their practice, and, unless we're saying that this is going to harm the baby, like, we should respect their wishes in wanting to do this for their baby. So in the end, we did allow them to do some things, but not all things, and it was the medical team in the end that met with the family and met with this person to decide what was safe. But I really got to thinking, like, I wonder what the thought process is, or what the opinions are of not just the people in my unit, but other units too. So the goal of the survey is to establish 3 main concepts for each complementary health modality, and looking at those specifically that are defined in that NCCIH model. So looking at NICU physicians, nurse practitioners, nurses and therapists, and asking questions to establish which complementary health modalities they use in their self-care or the care of their family, what the perception is on the safety and efficacy of these complementary therapies in the care of patients and families, and finally, what's their knowledge base for discussing these therapies with families from a scientific basis. So here I have a graphic just showing sort of the organization of the survey components. So the main areas, the personal use, the perception of the safety and efficacy, and then the knowledge base regarding each of the therapies that are defined under that, each of the main therapies defined under that umbrella of complementary health approaches. So wrapping up, this is a quote, and when I first, that 3 years ago when that family came in and I started, digging into literature and just looking, were there studies out there for abdominal massage with lavender oil, and just so that I could understand for myself what the research was and were there potential harm in that, or were there benefits. I came across that San Diego article that I mentioned earlier, and this quote really jumped out at me. And I thought, wow, we have so much technology, so many things that are, don't get me wrong, absolutely life-saving in the NICU that we're focused on, and so much in terms of low-tech, high-touch therapies that really take a back burner in our care, when it really is those things, those human therapies, that humanistic part of care that speaks to me as a nurse, and I feel like most aligns with the care that I want to provide to families to help them bond with their baby and help promote healing. So with that, here's a link to the survey, and I think that it did go out to everybody who's registered, but at the end of the slide deck, these are all the various references I talked about, but there's also, I think in your handouts, there's a flyer that you can use to post on your units and share with your colleagues, which I would be much appreciative of. So I think we can open up to questions, Kathy.
Yeah, great. Sarah, thank you so much. I think that last quote really hit home to me.
Yeah.
I mean,
Yeah.
all the money and everything we do to put on these big, huge things, and really, I've always said really that the hands of the nurse make all the difference in the world, and that includes a lot of these alternative therapies. So thank you for a really great evidence-based presentation. It was super. So we're going to open up for questions. There's a Q&A tab on the bottom of your Zoom screen, and if you just click on that and type your questions there, Kathy Randall is also on, and she's going to help field the questions. So Sarah will ask them to you, and then you can answer as they come in. So Kathy?
Yeah, thanks, Sarah. It was really, really good and comprehensive. I learned a lot. So there was a question on, if you can go back maybe a few slides to that, where you're talking about the homeopathy, and you had the colic babies. If somebody wanted to catch the actual species of the chamomile. So I think that's what the person was asking for, unless I think that was the only place you mentioned the chamomile. So for whoever asked that, there is your actual, I will not even try to say this, matriarchy something chamomilla.
Yeah.
L.
I know. But that brings a great point, because it is, I think, probably one of the most important things to understand is that you can't look at something and say lavender is lavender, or chamomile is chamomile. Mm-hmm. It's very important that when you're pulling research studies and looking at formulations, that you are looking at apples to apples, because there is a tremendous amount of variation out there. And if you go to that Herbalgram site there, that's that American Botanical Society, that has a lot of information to help you really understand all those different formulations and look for research specific to the formulation you're looking for.
Awesome. And can you clarify on that particular study, was that a topical application study? both of these that are listed here?
Yeah, so for the colic one, that was actually enteral. The lavender massage for colic, that was topical.
Okay, so the first one where you were talking about they were comparing the probiotics and the simethicone, and then this was actually a botanical extract combination that they looked at.
Exactly.
Okay. So that one was actually ingested, and then the others was topical. Okay, so I hope that answers. Somebody asked, was it massage? So I'm hoping that answers that question.
Yeah, but there are a lot of research studies looking at topical chamomile and aromatherapy applications with chamomile too. That's a pretty major one.
So even just, aromatic application, not even touching the baby's, no dermal exposure at all, just the aromatherapy itself.
Yeah, and I don't know specific to the colic, I'm not sure about that, but looking at pain and stress, I definitely have seen some chamomile studies for that. And they all have different mechanisms of action. So even when you're looking at the lavender, for instance, so looking at that linalool component and why it works for inhaled, the pathways that it works on when it's ingested or when it's topically applied are different. So, you can really dig into some detail in the research to say, like, this is why, and I think that's what, I think nurses are sort of overall more supportive. I mean, I suspect they are. I guess I'll find out when I get my research results back, but that's just, anecdotally what I think. But physicians seem more detailed into, I want to understand why you're telling me this lavender is going to activate this pathway. Like, why would it work the same as an analgesic would work, like a Tylenol? So when you're looking at the studies, trying to dig down to that level of detail, I think is the way to go if you're trying to advocate for a practice change with a physician.
I think you should say that 10 times. Because I think that answers a couple questions. So somebody was saying that many of the studies that you cited, especially there are two, I think, that are kind of most cited, which are the Iranian studies that were done. I'm saying that people don't want to believe them because they come from other countries. But
I know.
The NAS study was actually done in the US that you were just talking about.
It was. And when you think about that, why that is, why do we have this this pervasive notion that there is no research? And it's true that there's limited US-based research, but going back to look at the funding and the support, like, you're going to tell me that 60 people and $150 million can adequately say that complementary health approaches are not valid? That just doesn't make sense. So, I think that there's a systemic issue in the support that we have in our country for looking at therapies, designing studies to look at these different complementary health approaches to establish their safety and efficacy. And I mean, the reality is that there are so many studies that are randomized control trials that are well-designed studies that were just done in other countries. And I think it would just really be, I mean, I don't think that it would serve our patients to dismiss them. I think that we do need to look at them critically and analyze them. And I'm not saying that there aren't poorly designed studies out there, because there certainly are. But there are also really well-designed studies that deserve our attention. And like Kathy said, I think that clinical trial of the aromatherapy for NAS patients is going to end up being something that really acts as a catalyst for other studies to be done, because they did get investigational drug approval from the FDA, which is incredible. I think it's unprecedented. I can't think of another study that was done in the US that they got investigational drug approval, certainly not for neonates, for a complementary health approach. So
absolutely.
I think at this point, we can't ignore it.
Yeah, and I think one of the important things, there are so many safety profile studies done on adults as well, and that we can learn from the body chemistry from those studies. And they do apply. I mean, obviously there are times when babies' chemistry and biochemistry is a little different, but I think even looking at the safety of that, and maybe for the NICU, a safe place can be to start with parents, and maybe using some of these things on our parents' stress and emotional support for them as some potential opportunities for us to begin to integrate them in a safe way. Many hospitals, and I know Sarah, you can speak to this, even a lot better than me, are looking at even nurse wellness and as a way to begin to integrate it into the unit and to just allow people to begin to become comfortable. So I don't know if you want to speak to even some of that side of how do you introduce to your unit even just these ideas? And I think Tara, that's getting at a little bit to your question, I think, where she was asking about, do you find staff to be resistant? And how do you even start?
Yeah, I think that Kathy brings up a great point, that starting with parents, starting with staff applications can be a great safe place to start. I do like the idea of the BioS patches, because so they were at at Kathy's conference, at the one conference that we just went to. They were a vendor there, and the patches are on that Zaki hand. You can't really tell in the picture. Let me see if I can go back to that. So that little white patch that's on that Zaki hand, it has a hydrogel backing. So it sort of, I think, is a much more concrete idea versus, dropping oil onto like a cotton wick or something like that and having the aromatherapy applied that way. And a lot of places, I think you'll find, will not allow you to use a diffuser in a patient care area. Some places I think do. I know my hospital will not allow you to use a diffuser in a patient care area. So that might be a way to go to look at not just what you're trying to do, but how you're trying to deliver it. I would definitely talk to a manager first and assess what their support is of your project, because you are going to get people that have very strong negative opinions about what you want to do. That's just, I would say that probably exists anywhere for anything that you're trying to do. There are always people that, for whatever reason, instantly go to a negative place when you're trying to implement a practice change. And so I would anticipate that and be ready with your evidence and be ready with your manager's support, pulling up policies. So looking at what policies your hospital has, you might be surprised to find that perhaps things are being done in other care areas, for instance, in oncology. So in my hospital, we're not using aromatherapy in the NICU. However, they are doing things with aromatherapy on the oncology floor for nausea. So, you might have a system in place already in your hospital that you're not even aware of. Seeing if your hospital has an integrative medicine department, they may, and they might be so small that you don't even know that they're there. So, seeing if you can figure out what the hierarchy is at your institution can be really helpful. And looking to your multidisciplinary team, because I think that you'll find a lot of support comes from like the physical occupational therapy area. They, at least in my hospital, I feel like they are very supportive of.
And child life.
And child life, that's another great one. Yes, child life. Very supportive of bringing these complementary health approaches into our care.
Yeah, I know it's being used fair amount in, say, PACU and pre-op. And so if you're a NICU that's inside a larger adult hospital, you may, like you said, find those partnerships in these unusual places and find, like you said, the policies already exist.
And starting with something small. So thinking of launching a large, robust aromatherapy program in the NICU, like that, that's just a really big undertaking. But thinking of a small project that you can do, and I think starting with staff, starting with parents is a great idea. And saying that, you know, for parents that their child is undergoing a surgical procedure, we're going to offer them aromatherapy, you know, while they're in the waiting room or something like that, like while they're waiting for their baby to come back, like coming up with something, some very specific application that's going to be a small subset of patients or parents to get started.
And I think one of the really cool application techniques for maybe parents would be those personal inhalers where you can put a couple drops on these little cotton wicks and they go into a little plastic container, and then the parent can open it, breathe it, close it, and that kind of, I think, keeps it contained and keeps it personal and doesn't have that risk. I think that people are concerned that when you talk about maybe bringing it, like you said, even into the waiting room, that we're talking about plugging in 5 diffusers or 5 plugins into the wall, and that it's going to be for everyone and not always what everyone wants. And so I like those, and I know that other places, you know, the BioS patches are awesome, but these are other ways that I've seen places do that as well. So just so people know, there are lots of different ideas for that. So Jean wrote something just about that you know, FDA doesn't really regulate these, and drug companies may be blocking some of the funding. And we won't get too political, but I think that Sarah and I will just say we agree.
Yeah, and I would say, going back to that website, oh wait, where is it? That the American Botanical Society website, there is a really great article talking about, educating about how these products are regulated in the United States.
Nice. It's not that they're not completely, but I think I get what your point was, Jean, in saying that maybe there's some other financial incentives that are getting priorities. And I think that's where, you know, as healthcare professionals, as nurses, physicians, therapists, I think that's where you use your voice, your own personal, you know, professional voice, just to either advocate for this or to learn more and to become, you know, at least an educated, you know, an educated educator of our families as they come in and ask for advice, or someone's recommended something to them, and having something that you can share with them, I think is a really valuable place for us to be as healthcare professionals. There were 2 comments, and so I'll just kind of combine them into 2, which is just there were 2 case studies that are available on the internet if people look, talking about lavender and gynecomastia, precocious puberty, and I wondered, Sarah, do you want to address that?
So what was the question?
So the question is, have you heard of the studies that are linking lavender to precocious puberty or gynecomastia?
Oh, yeah. So I have read those studies. I think that we certainly need to understand what the dose-dependent effects are. So I think that if you dig into those studies a little bit more, you'll find that to create effects like that are not the doses that we're talking about in these neonatal studies. But certainly that is a long-term effect that we should be looking at in the research. And I would also say that there are a tremendous amount of other endocrine disrupting chemicals that are all over your NICU. So if people are worried about the lavender, I would say that they should also be looking at things that we are using every single day in most NICUs that are probably creating the same effects.
So you're talking about things like preservatives, which can be endocrine disruptors, things like parabens and phthalates, things like DEHP that were, you know, widely available in IV tubings and feeding tubes until a decade ago. And I think if I remember, one of those lavender case reports was actually the use of a lavender scented body lotion and was used in a lot and a huge amounts. And it was not really the aromatic effect as it was more this lotion. And it was likely a lavender fragrance and actually not lavender botanical at all, which we know those synthetic fragrances have those endocrine disruptors like phthalates and other things. And so I think I think lavender itself has gotten linked into that, and it was just lavender scented. And I think for what you're just saying, there are many other endocrine disruptors that we should probably be concerned about at a higher level and higher exposures than this. So I would say at this point, there's no evidence to say it's a contraindication for use. There are certainly a lot of cause for concern for some of the other endocrine disruptors, but I would not be concerned with lavender either. Do you want to tackle CBD?
So
in any way?
CBD, I do, So I do talk about, CBD is something I ask about in my survey about just what the perception is. So for the CBD, I would say that we do definitely need more research in, I'm not aware of any neonatal research in the use of CBD. I don't know if Kathy has seen any studies, but I think there's potential there. There are definitely mechanisms of action that would be desirable, or effects that would be desirable in the neonate, but I don't know that we can say enough to say that it would be safe to do any sort of pilot studies. But I think that there is definitely potential for benefits, not just in the baby, but also in terms of like sleep and stress management in adults for sure.
So this person was saying they're in California. So, and living in California, I know this this controversy is a hotbed for us. I think just to be clear, I think too, it's really challenging because most CBD, even if it says no THC, does have some trace. And I think that becomes complicated as well. And the other piece is that there is a lot of research. The CBD works on what's known as the Endocannabinoid System, and there is a lot of really solid evidence for use of that. Activating the endocannabinoid system, but there are other more concentrated botanicals that provide activation of some of this, in some of the receptors. So without some of the psychoactive parts. So I think if I was in the NICU and wanting to pick something, I think I would go with something that already been studied and save some of these other compounds for later, when I think we don't fully understand them even as well as we could for adult uses. And that there are so many other things that we could try in the NICU for our families and for babies and for caregivers way before we get to endocannabinoids, which is, I think, is pretty advanced uses. So Jean was asking a little bit more about auditory nutrition. So Sarah, I know that's a passion of yours, and maybe we'll have to do a follow-up webinar on that. Or if you Google Sarah's name and language nutrition, she's done other webinars other places, and you'll be able to find that as well. Oh gosh,
and she could email me too if she wants that. At that
Perfect.
email. Because
Sarah, do you
it's definitely a whole other topic.
So do you remember in the aromatherapy lavender studies for pain, what was the placebo for the control group? Nothing, or did they actually do another one? Do you remember?
It was nothing. It was what they call like a blank aromatherapy. So there was no scent. There was no aromatic compound. And I think they used some sort of like blocking, some sort of mask thing for the researchers so that they wouldn't know what they were giving. Or no, maybe it was that the people scoring were I'm trying to think. I looked at so many studies that they're,
Yeah, no,
they're
it's
blending
okay.
together in my head. But because I was trying to think of how the people giving the aromatherapy, I think that's what it was. I think the people that were giving the aromatherapy were not the people that were doing the pain scores.
The assessment.
That was how they blinded it. So that they were, to the people that were viewing the baby via like a video and giving the scores, they didn't know if it was the blank aromatherapy or the lavender aromatherapy.
Perfect. And I think I saw one study that one time used rose oil as the placebo, or as at least as a confounder, or whatever you want to say, another arm. So they had like a rose and a lavender, and the lavender still demonstrated more statistical.
There's probably, I would say if you're going to start anywhere, lavender is a great place to start because there are so many studies out there of all different applications of lavender.
Yeah. Let's see, someone's just making the comment that they have personally started using eucalyptus and lavender, and they love sharing with their patients' moms to just breathing deep and just trying to help them, use some of the techniques you mentioned about reducing stress and anxiety for our families as well. To do that and to really help soothe and heal, right?
Absolutely. Yeah, I think it's so important.
Yeah. I'm going to leave this one, Jean, for another time because I don't know that we have the evidence on any of that at this point. So thank you. Any other questions coming up?
If not, it's Kathy Bush again. I'm going to move us along. Sarah, thanks so much for taking the time to answer all those questions. They were really good questions.
Thank you.
Audience. So again, the webinar was brought to you by DandleLION Medical, and we are so grateful to have people like Sarah that are doing cutting edge research and really, interested in doing the best things for babies, to have you as faculty on our webinar. So thank you again, Sarah.
Thank you. It was my pleasure, Kathy.
Thanks. To all of you listening, we hope that you will like us on Facebook or LinkedIn and be the first to find out about what's new at DandleLION. We are getting ready to launch Sweet Cheeks, our new 40% glucose gel in an orange syringe. You'll have an opportunity in the evaluation to indicate if you'd like to receive samples of the new Sweet Cheeks. So in order for you to receive your free CE, I want you to go look in the chat area and you will find a link to the evaluation. If you're watching the recording, please go back to the email you received with a link to the recording and click on the link to the evaluation form. You will receive an email with a PDF of your CE certificate within 24 hours after you finish the evaluation. Be sure to check your spam if you don't receive the email within 24 hours. If you're watching live and you don't have time to fill out the evaluation right now, or your hospital has blocked access, you'll receive an email within a day or so with a link to the recording, and the evaluation link will be on there as well. Just one last thing, if you are viewing as a group, each one of you has to log on individually to the evaluation form in order to get the CE. So our next DandleLION webinar is on April 7th. We hope you'll check the website and to find out what that will be, but you'll also, once you're signed up for one webinar, you will get information about future webinars. Again, thank you all for listening and being such a great audience, and many thanks again to Sarah for a great webinar.
Thank you, everybody.